And welcome to Health Matters on Channels Television. Thanks for staying with us. I am Mary Alale Yusuf. The global figure for COVID-19 as of September the 18th was upwards of 30.5 million. More than 20.7 million people had recovered, and there were more than 950,000 deaths. In the same time frame, 56,956 infections were recorded cumulatively in Nigeria, out of which 48,305 have recovered and 1,094 died. The overall recovery rate was up to about 85%. Mortality rate is steady at 1.9. So far, 472,191 samples have been tested. A lot of study is being conducted to determine the nature of the SARS-CoV-2 virus to get a possible cure and roll out effective vaccines. Here in Nigeria, there are also studies to progress in the fight against COVID-19. We'll look at some of these studies and possible inroads to manage the novel virus. My guest is Deputy Director of Research at the Nigerian Institute of Medical Research and Head of Infection Control and Biosecurity. He's also a consultant obstetrician and gynecologist. Dr. Gregory Ohihoin, you are welcome to the show.
Thank you, Mary. It's a pleasure to be here, as usual.
So we have a situation where numbers are declining. Some of that is being attributed to less testing, a decline in testing. You are doing a study, a kind of survey. Can you tell us something about that?
Great, thank you. The Sero-EPID study is what the Nigerian Institute of Medical Research is currently undertaking, and that study is very key. Reason being that the study will help us determine the number of people who are actually exposed to this virus, those who have been exposed to the virus. So Sero-EPID, in the sense that we are going to pick out antibodies from the serum of individuals. That is, these individuals and may not be actively, in fact, they're not actively experiencing the disease condition now. Probably,
but they have been infected.
Yes, they've been infected and they never knew, or probably they knew. So we are going to go ahead, take their blood samples, test them. So we are using blood this time around, not oropharyngeal or nasopharyngeal samples. Okay, and find out if they've been exposed. In the same vein, we are still going to do the usual, swab tests to also look at.
So it's a double.
Yes, double study. So it's a huge study to go around the country. Say about 6 countries.
Are you knocking on people's
6
doors?
states. Yes, it's going to be in the community. 6 states in the country will be covering. Partners, other institutions are covering other states, but the Nigerian Institute of Medical Research will be covering 6 states. We are going to go to their houses. It's a household-based survey.
Okay,
we are going to interact with them.
Wait, just a moment. Other institutions are covering other states?
Yes, there's. I know that University of Maryland, Baltimore, they are working through the USCDC. They received support, to conduct some other states. So it's going to cover the whole country. And by the time this study is done, we are using the same platform, the same base. So we are working together in a way.
So you're going to collate all
Yes,
your
collate.
studies.
And we're going to determine the number of Nigerians. We are going to use what we call mathematical modeling at the end of the day to determine the number of Nigerians. And we'll have a figure of those who have been exposed to the virus. So we can determine how close or how far we are from herd immunity. Herd immunity, you are looking at about 60% of the population exposed. So we're going to be able to find that. So it's a very useful study. We're going to be able to plan.
Will these numbers help you interpret the number of tests we've done, sort of show you how far we've gone? Are we on course, or
Yeah, because we're going to get the figures into the national database, so we can determine for sure to know those who have been exposed to the disease. We'll know the number of people. We can have the real figure for Nigeria.
Okay.
As we speak now, we don't know the real figures. We know that we are more than we can determine the actual case fatality rates. To find out what is the real case fatality rate, because we're going to get the true denominator.
It might not really be 1.9.
Yes.
We've been steady at 1.9 for so long.
So we're going to, the picture will be clearer, and this data is important. I'm so happy. I'm so excited about this study. I'm so proud of the institute and the general of being a part of this great study, because we are going to truly know what the situation is in the country, so we can make projections, we can plan how to tackle the problem. You can't plan to tackle the problem, you don't know the extent.
Okay.
So for the first time, by the time these studies are going to last for 1 month, so I encourage the citizens to open their doors to these researchers to come in to be able to perform this study. So we are going to go from one house to the other. We are going to go around different households. We are going to interact with the family members. We are going to collect data from them. We are going to take blood samples from them. We are going to take oropharyngeal samples from them. We are going to do it for about a period of 1 month, around the country, different selected states.
For a study that wide,
yes.
Don't you think 1 month is a bit?
No, we are working with a large team also. We have the core investigators. I'm part of the investigators. We have the core investigators. We have the field workers. It's a huge study. If you see, when we have our meetings,
This looks like what was done for AIDS.
In a way, yes, similar. Yes, other countries have done theirs. Like India, they've done theirs. That's why they could get their figures. Spain have recently done theirs. That's why they have their figures. I was following the program earlier on in Sunrise, and I saw somebody was saying that we've not started doing, epidemiological studies. I was just smiling.
You're talking
yes,
about
so I was.
How long have you been on it?
It's the preliminary work. It's the research work. Is the end result you see. We've been on this. We've been having sleepless nights on this for months. We have to write a proposal. We have to validate the test kits we are going to use. So there's a team in the laboratory that is working on validating the test kit. Because if the test kit is not correct, if the test kit is not accurate, you're not going to get the right result. So I've been going back and forth trying to validate the test kit we are going to use for this study. Then we have a team who is involved in writing, doing the writing, the thinking job. We have a team who is involved in logistics. So we've been on this for months, having sleepless nights to put this together. But I'm happy to know that we are going to the field on Monday.
This Monday.
This Monday we'll be in the field.
Let's talk about test kits. NIMR has a new invention.
Yes.
The SARS-CoV-2 isothermal molecular assay.
Yes.
SIMA for short. Tell us about SIMA.
Yes, SIMA is a great innovation. And I tell people that if you are a scientist, you are not in NIMR, you will feel sad for yourself. Because a lot is happening at the Nigerian Institute of Medical Research, thanks to Director General Professor Babatunde Lawal Salako. So SIMA is a molecular-based test, different from the conventional PCR that can give you the SARS-CoV-2 result in 40 minutes.
40 minutes?
Yes. So it doesn't mean that it's going to replace the conventional PCR. In fact, you use some of the platform used for the PCR, you can also adapt it to use for SIMA.
But if I'm going to get an accurate test in 40 minutes, wow.
40 minutes, accurate test. The sensitivity and specificity, what we use to rate tests and quality is near 100%.
And this was made here?
Yes. We have our scientist, Dr. Owoma, who was involved in developing the test kits in our laboratory here in NIMR. So a lot is happening here in the country. Just need support. We need people to invest into research.
Okay, so since you have this new SIMA that can do tests so fast, how are you going to help ramp up testing?
Now, you see, one thing, when people get excited when we talk about the turnaround time of test kits, but it's going to serve a unique purpose. I'm emphasizing that it will replace our conventional PCR.
Okay.
But I'll give you an example. We have recently, I realized that the PTF were complaining that people came in with results that were not
fake
accurate.
Certificates,
yes,
negative,
that were not accurate, and it took a while for them to pick this out. If you have SIMA, you put it at the port of entry, and you can run that test and get your results out in 40 minutes before you allow them in.
And you can be sure that the result is accurate.
Yes, it's accurate. So that can play that unique function for us. And you can take it to the field. If you are doing field work, you need the result, you want to upload that result, you can also use it in the field. So it's easy to use. The interface is easy for anybody to be trained in it. Any scientist, when I mean anybody, I don't mean anybody generally. Any scientist to be trained in it, to be able to use that interface and get accurate result near 100%. It's a molecular-based test. It's not antibody. You get that result.
Different from the PCR? What's the difference?
Very good question. Now, the big difference is in a step in the procedure, in the molecular-based test. There's what we call the reverse transcriptase enzyme that converts, SARS-CoV-2 is an RNA-based virus.
Yes, RNA.
So it converts it to the DNA, before it amplifies it. Okay. Now, that step in conventional PCR can take up to anything from 20 to 30 minutes. In SIMA, it is done in 6 minutes because there's an adjustment in the temperature range to be able to get this done, because it's called cyclic thermal process, an eating process that takes place in the conventional PCR.
So it changes it to DNA.
Yes, change to DNA
and reads it.
Yeah, and reads it and amplifies it and reads it and make complementary DNA. What we call complementary DNA makes more copies of it for you to be able to interpret. So that's the advantage. Okay. That process, conventional PCR, will take up anything from 30 to 40 minutes, but in SIMA, it is done in 6 minutes. It's done in 6 minutes, so that makes it fast. So you gain time from that. So
This could be a game changer here.
Yes, it is. I mean, it will definitely make a big difference. About not just the quantity of tests. Of course, we can do a lot. There are other modalities you can use to do a lot in terms of number of tests you are going to do. But you can deploy it for unique use. So you can use it in planning. You know, the principle of managing very contagious and communicable diseases is the same. You have what you call active case searching. So this is going to be useful for active case searching. So you identify the cases, you can isolate those cases, okay? You can isolate them so that they don't infect other people. So these are the advantages you can get from this. Then you can treat the people who are infected. So in that way, you're going to minimize spread.
Are you going to deploy this new technology in this study that you're doing?
Well, we don't need to. We have other platforms. We don't need to use it. But it's just the advantage that it gives, unique advantage. Because remember that the main aim of the study we are doing now, the serorepeat study, serological study. So we're using blood to do antibody. But of course, because it's a research, we are doing other things. There are a lot of things we are doing, a lot of things. I can't give the details here, but we are doing a lot. We're also going to take samples also for oropharyngeal and pharyngeal samples and still do the conventional PCR for SARS-CoV-2. So we're going to do that. So we're going to also find that out.
So you are going to be taking blood.
Yes.
If you see antibodies, that person is checked as having been exposed.
Yes, so that can
when you do the oropharyngeal 1-2 and it's positive, that person is checked as having been exposed, but also isolated.
Remember that some people that will have antibodies, they've already recovered.
That's correct.
So they're not necessarily at risk of exposing other people, because you have two kind of antibodies.
But that's the other thing.
Yes.
They say that you may have antibodies, you may have recovered, but that doesn't guarantee that you are immune.
The thing is that there have been 2 reported cases officially that I'm aware of people who have been exposed, had SARS-CoV-2 infection, recovered and got exposed again. Yes, I mean the reported cases. So you have to report a case to know. Of course, we know. I know anecdotally, that is, I know from I know a colleague in particular, a friend who was positive for SARS-CoV-2, recovered and became positive again after that. Okay, that case was not reported. So I'm talking of reported cases.
Okay.
Now the implication of that is that the duration of protection of the antibodies you have is not forever.
Okay.
So you are going to watch out and realize that though you have been exposed and you have antibodies, you can have that. You can still be exposed again, and you can have the infection. But what people have realized is that for those who are having a reinfection, okay, if the first time they had it, they dealt with the virus, okay, it means that they have a good chance of dealing with it again. Okay. That's one point.
That's what the antibodies are about.
Yes. Secondly, another point is that it means also that it's possible that they may not have very severe forms like before, because they've been exposed to it before. So these are all possibilities. But what will answer those questions is research. That's why we must invest in research to be able to answer all of these questions that I'm raising.
Okay,
so the picture will be clearer.
Go ahead to talk about something that came out, a while back, the RNA extraction kit. Has that? I know it's been deployed, but how successful has that been?
That's what we are using now for most of our own work. So we are using it, for our own RNA extraction. We are encouraging others to use it. So our own as scientists and researchers to develop these things, invent them. And we need people to also patronize us. There's a commercial aspect that may not be our area of strength.
Just, in a short 1 minute, can you explain to people who might not understand what an RNA extraction kit is? What does it do?
Okay, great. Now, you need to be able to, let me make it as easy as possible. Now, to be able to test anything, you have to bring out what is the active component of that. In the case of SARS-CoV-2, it's RNA.
Okay.
So if you don't bring it out, I'm just using that as an example, and this can apply to other disease conditions. So the active component of any infectious agent is molecules. That's why it's called molecular technique.
Yeah.
It's the molecules, and these molecules are genetic molecules. It could be DNA. It could be RNA. In the case of this particular SARS-CoV-2 infection, it's RNA. So you need to be able to isolate it and be sure that that's what you are testing. That's important for the test. Remember that this is the principle you use to develop vaccines.
Okay, I've got to pause you there. We'll go there when we come back from the break. Please stay with us. We're going on a short break. Welcome back. It's Health Matters on Channels Television. Call 0808-054-2233. The number will be showing on your screen if you have questions about developments in COVID-19 investigations. You can also tweet at CTV_Mary A. We're talking about RNA extraction kits, and you said this can help you with a vaccine. So are we looking at a vaccine?
Well, globally, a lot is happening, but I'm just trying to let you know that
here,
we can, but we need more support. I brought that in so I to understand that
we have the
capacity.
To do it.
Yes, we have the capacity. We have the human capacity. Just recently, our General Professor Batande Lawasalako sent some scientists just before this SARS-CoV-2 era to China, develop some skills. Some scientists go to Gambia, go to other places of the world to develop skill sets, but they need infrastructure. They need support. Research is expensive, very, very expensive. So we need to invest for them in terms of the brain and the intellectual capacity. They have it, but we need the infrastructure to do that. Okay. So that forms the basis of vaccine, because you need in vaccine development you need to be able to isolate the molecules. In this case, genetic molecules.
Yes.
Like the and develop antibodies against it. So that's what constitutes what makes a vaccine. So if you are unable to extract, so this is a huge step, some of these genetic materials, are you going to form the antibodies against it? So for us to be able to think about things like vaccine, these are some of the, what I call baby step to be able to do that.
Okay.
Principles are universal. The scientists have the knowledge. They need more training, of course, but as it is now, they have what it takes.
Knowledge is not lacking.
Yes, it's not lacking to develop.
Let's talk about the Oxford vaccine.
Yeah.
We always talk about the Oxford vaccine. We're looking forward to the rolling out and everything, but then this hitch, somebody developing a potentially serious case of transverse myelitis, and it's been stalled. Now, here's the question. Does this usually happen? Is it a concern? Or does this usually happen with other vaccines that people have tried to roll out?
Yes, it's just because a lot of people are conscious of SARS-CoV-2 because it's a global pandemic. But this happens in every clinical trial you're doing. People can have reactions.
And the vaccine still went on?
Yeah, you see, you have to first of all find out whether the transverse myelitis, is
from the vaccine.
Exactly.
Or a
but
placebo.
The way clinical trials are conducted, if you have any form of reaction, irrespective of whether it's related to it or not, you have to stop and investigate.
Okay.
That's why it's a trial. But of course, other vaccines, the Pfizer vaccine is going on, and AstraZeneca vaccine is also going on, and they're developing.
AstraZeneca is the one that was paused, unless they have two.
Yes, AstraZeneca was paused, but the Oxford, the Pfizer vaccine is still going on. It's still going on.
What about Sputnik?
People are in different stages. All of them are making progress. But what I want to say about the vaccine that is very important is that as we speak, we know that sooner or later there will be a vaccine. But we don't have it yet.
Okay.
We don't have it yet. You are making progress. They've crossed some major milestones. They developed neutralizing antibodies. They demonstrated safety. They are in phase 3 now. All of them are in different phases, and they are making good progress as it is. But we still don't have it. We still don't have it. Despite the enthusiasm about, University of Oxford and their team, you saw what happened, at the end of the day. So the vaccine that we have now is still to make use of our face mask, and to use our hand sanitizers,
and
to engage in physical distancing.
Physical distancing, yes. It's good to change the name to physical
isolate
distancing.
People.
Yes.
So those are the 3 key things, and these are proven techniques, proven public health measures that are effective. Of course, there are wonderful prospects with the vaccine, like you said. But again, look at the setback we had from the University of Oxford group and what they've suffered at this point now. Of course, they can still progress with it, but we should look at what is effective now that we know. Proven, effective
techniques. That's all we have now.
That was what we have now until we get that vaccine. And even if we have the vaccine, let me just make a note of warning for the vaccine. Even when we get that vaccine, which is almost inevitable, I would say, we have to understand that there's what they call distribution of vaccine. We are not going to all have the vaccine at the same time.
It's not going to be an automatic
thing. So they're going to be priority areas. They're going to be people that participated in the trial, countries that participated in the trial. They're going to get preference. They're going to classify also people who are at risk, frontline net workers.
Okay,
those
so
who are aged,
where does that leave Nigeria?
Yeah, so it makes me worry, to be honest. But because if you look at it in terms of hierarchy of list, we are not. Our country is not being selected as as a trial center. I know they are doing in South Africa. I think in Africa they picked South Africa. They're doing in South Africa, and that is an advantage. In terms of, although the African CDC is trying to form a coalition to ensure that there's equitable distribution of vaccine when it arrives, But if you want to look at the way they classify
WHO is doing a network of labs in Africa. So doesn't that count for anything?
It may, but again, just if you want to triage, you have to triage in order of those who invested, the countries that invested in it, the countries who are buying, the countries who contributed towards it in the clinical trial phase, people who participate. These are the things they use in equitable distribution. Then, of course, you have to look at other countries also. African CDC, I know they are trying to ensure that there's equitable distribution of vaccine. It will get to us eventually, but we have to train our heart big and play big roles.
Okay.
In it.
Let's talk about something else since a vaccine is not out yet.
Yes.
Spain, France, Poland, and some other European countries, they're having numbers that they haven't seen since March. And people are going as far as to say this might be a second wave. Now, with ease on travel, what happens if some of this stuff enters Nigeria? Are we ready?
Well, it's a very good question. Those are the things we should be looking at. We have to make our borders very tight. We have to be sure of the SARS-CoV-2 status of those who are coming to this country, our nationals, foreigners who are coming in, and that's why I said that CIMA could play a big role in that.
But if we are careful, could we totally limit the entry of infected people into the country?
Why not? We can.
I'm saying this in respect of the 3-day, 72-hour cutoff on negative certificates. How useful is this? Couldn't somebody just come in negative and they end up being positive? Something we've seen before.
Oh, that's that narrow period. That's why I mentioned again that if you have a technique that can give you results in 40 minutes. It brings me back again to this innovation by the Nigerian Institute of Medical Research, our innovation, that you can, if somebody's coming with a result, you can still go ahead and conduct a test at the port of entry and get that result out within 40 minutes.
Okay, let's quickly take a phone call. Hello.
Hello, Hey, how are you?
Very fine, thank you. What's your question?
My name is Dr. Henry Edegre. I'm calling from Abuja.
You're welcome.
I am very proud of your respondent there, Dr. Nimoy. I've been worried since this COVID-19 thing came out that this country is not doing anything about research development. And I just stumbled on your program now and listened to that gentleman saying the things I expect we have been doing in this country all along. He mentioned active case search. There is something called sentinel surveillance also he knows very well. We are not doing anything. You are relying on the very few number of you are testing and telling me that COVID-19 is not around. It doesn't make sense to me. I've been privileged to have over 47 years in public health. For any disease like that young man, Dr. Nimoy said, you try as much as possible to look at the root cause, which is what they are doing now. What is difficult in on COVID-19?
Thank you. Thank you so much, Doctor, for your contribution. We appreciate it. Do you have anything to say about that?
No, I think he said it all. And the fact that we need to do a lot in terms of surveillance. I mentioned about active case search. You have to pick the cases.
Okay.
If you don't pick the cases, you cannot prevent the spread.
Because you can't know your numbers.
So but we're talking about the port of entry. At the port of entry, we can do a lot.
Okay, Doctor, thank you so much. I have to stop you there. We're out of time. As usual, it's been so interesting. Thanks for staying with us. And be safe. Please be safe. Wash your hands. Keep your physical distancing. There's no vaccine yet. And go to the podcast, channelstv.com/podcast. Have a wonderful day.